know we've all been frustrated by people spreading those lies, people not taking this pandemic seriously and politicizing it and then it turning into now people watching more people die, right? So what TLS wants to do is get rid of the lies and shenanigans for a minute and just let you hear the truth. There's plenty of lies and misinformation in coronavirus. So Truth Lies Shenanigans brings you the truth. Stories directly from the people that lived it, frontline workers and survivors. This is the COVID Chronicles. Welcome. For the first in our series, we have Dr. Emma Bendu Ekanatum. She's been a doctor for 10 years in the field of family medicine, born in New York to immigrants from India. She trained in the Bronx at Montefiore Medical Center and has been working at Columbia New York Presbyterian for the past 6 years in the hospital inpatient setting, where she treats patients and trains resident physicians. She also lives in the Bronx and spends most of her time outside of work with her 2 daughters. So welcome, Dr. Ekanatum.
Welcome.
How are you?
Thank you. It's nice to be here. Thank you for having me.
So did I miss anything? Did I get it all right?
I think you got it all right.
Okay. Well, thank you for joining us.
Welcome.
I want to just start it off. Can you tell us a little bit more about what you do currently at Columbia New York Presbyterian?
Yes. So our hospital is a small community branch off of a very large hospital system of New York Presbyterian that exists in New York City. And there we take care of mostly adult patients, though our specialty takes care of all individuals, pregnancy, babies, children, adults, elderly, everyone. Our inpatient setting is only adults. And I work within Columbia's residency program for family medicine, where I train new docs within Columbia's family medicine program through their 3 years that they have of training to make sure that they are proficient in being able to care for patients in the hospital. And our hospital serves the Washington Heights Inwood community. If you don't know New York City very well, or Washington Heights, that's the uppermost part of Manhattan before you get into the Bronx. And it is very, very diverse. Most of our population of patients comes from the Dominican Republic, but we have a smattering of all different types of people from all countries around the world. And that's part of what we love about our work. I get to practice and learn more Spanish every day. And that's just a little taste of what our hospital's like.
Okay, thank you. Now, I'm glad we were able to get you on because, as we know, just a few months ago, New York was ground zero for the pandemic. At the height, New York was seeing like nearly 1,000 people dying every single day. So can you describe a bit about what you were seeing during this time with your patients?
Yeah, I think the last Friday the 13th that we had, which was March the 13th, was the most memorable day for me. That's when I realized, like, oh, this is getting real now, and we are so unprepared, we're so behind, and we are going to lose so many people if we don't get our stuff together right now. In the context, people were just coming in with all kinds of symptoms that in our daily work, or even in my life, I have 2 kids under 5, like cough, runny nose, sore throat. Those are things that I see like 10 times a day on the regular. And now every one of those symptoms has to be taken seriously as potentially progressing to this deadly illness. And I realized so quickly on that day, when patients we had already had in the hospital for 5 or 10 days, they were like, hey, I have a little sore throat, I have a cough, and you've already been in here 10 times to see me, so have 10 other people. And now we don't have that many tests, we don't have any protective equipment yet. And I realized how quickly we could all be like wiped out with having unknowingly spread this illness to each other. And very quickly, in a couple of weeks, we lost so many people from not only in our patient population, but in our colleague circle, who had to be out on quarantine just because we didn't have the guidelines to be protected in terms of masks in every room, equipment in every room. And it was it escalated very quickly, and it was very unarming for people in medicine. We're very used to being in control and having plans and lists and things to check off, and it was very disarming.
How many patients would you say that you may have lost of your patients?
I've just been actually going through ours. Actually, on my watch, I lost about 30 people.
Wow, wow. Lizzie?
What specific COVID training did they give you or your staff? Like, did they sit you guys aside and say, listen, this is going to be the new protocol. These are going to be the new steps that we take moving forward when when someone comes into the hospital? Like, how did they prepare you guys for this pandemic?
Um, we did have protocols, and they came too late. So, in terms of
Mm,
preparedness, in the beginning, our New York State's first case, I believe, was in another small branch of New York Presbyterian. And they told us, it still seems manageable. Healthcare workers should be safe. Our nurses and our own doctors were told in our hospital, for specific patients who come in with certain symptoms or who have traveled to specific countries like China, which was what we were told, which turned out to not be useful at the
Right.
end of the day,
Yep.
right.
which is a whole separate conversation. um, that only in those specific situations where you're talking or conversing or treating those patients do you have to wear masks, and only weeks later did we everybody has to wear masks at all time. So the protocols came too late, and that's why I think at the beginning of the pandemic is where most health workers were exposed, and most got sick and were out on quarantine.
So we have
And so then,
online. Oh, good.
sorry, go
No
ahead.
question. So we have online. Rupka says, "Thank you for your service. God bless you." Um, and I just want to let everyone know online. If you're online, please feel free to ask questions. We will be looking through and scanning, so feel free to ask your questions there. Lizzie, go ahead and continue.
I was just going to ask, so you mentioned, early on, like some of your fellow coworkers were getting sick or were exposed or what have you, so then they would have to quarantine. So then how do you fill those positions? Like, if a few doctors, nurses are out, is that it? Or is there like, a backup staff that's ready to come in? Like, how does that process work?
It's a good question. So it depends on where you're coming from. So family medicine in New York in general is a small entity, and is a small entity within our hospital as well. For example, I have 18 residents in our program, which is six a class. At any one time, my service is made up of three or four individuals outside of myself. So, if we all see one patient who has the virus and we were exposed, it could have wiped out our entire service very easily. I would say by nothing more than luck, we managed to survive, but we had to very quickly come together and make a plan as to how we were going to divvy up our literally person resources that we had available. And we had to shut down a whole bunch of other places in which people normally work within our department, whether it's the clinic or on other services, and get more bodies in to fill in, have more bodies on sick call if we needed backup, if someone was out sick. And all said and done, even with that system, we could have easily been wiped out
Wow.
very quickly.
Jam.
We got lucky. In the rest of the hospital, we had resources coming in. Like there were a bunch of travel nurses who were coming in who were wonderful, and we were so lucky to have them dedicate their service to helping these patients. Um, so that's how, in brief, we dealt with it. But we got lucky.
Jam.
So I have a million questions for you, but is gonna hit you with a more general question first because I'm curious. I was listening to an article, and they were saying that the amount of virus that you're exposed to likely determines how much of the virus you exhibit, how much you take on. Do you know anything about that at all? Can you? Do you?
Yeah, unfortunately, like a lot of medicine, but the coronavirus is a really good example of how humbled we should be as doctors, though I feel like many in my profession are often not. We know so little about the truth about this virus that any theory that you hold could be not true tomorrow, and that's true for like so many of the different treatments we tried at the beginning of our peak and at the end of our peak. I have also heard that virus will mount in terms of exposure and how much you're exposed to. That being said, I've seen a lot of other cases where, for example, 90-year-olds who had no contact with the outside world except for having their groceries delivered to the front door got sick and intubated and died. So,
Wow.
you know,
Oh my
it's
God.
there's a lot of different factors that are playing together, like what kind of conditions you have to start with that you're suffering from, chronic conditions, lung diseases, etc. How does your immune system react to things like normal allergies at baseline? Even those kinds of things play a role in terms of how your immune system is going to react. What we're finding out more and more is that a lot of why this disease is so horrible is because of the inflammatory response that is created in your body and how that can literally kill you while trying to fight at the same time.
Huh.
Z,
Wow.
That's like the
Uh,
shortest answer.
yeah.
good answer.
So I think I have a ton of questions too, but I think the one that's most pressing on my mind is, are hospitals and medical facilities ready and prepared for the second wave? And if so, how are they preparing?
Great question, Z.
I think we are trying to prepare. We have had preliminary meetings that involve everybody that should be involved: social workers, our nurses, our doctors, our admin, as to what should be done the next time around. I'd say we are somewhat prepared, but nobody really knows what the second wave is going to look like. And ultimately, the biggest problem that we have is the communities in which our patients are coming from. They are not equipped handle the disease, for one. Number two, prevent the spread.
Wow.
It's an underserved urban environment. Social distancing, I heard you guys say there's so many people who don't want to wear masks or who want to continue to get together in person, but social distancing is a privilege for many of the patients in our communities. They don't have the luxury of being able to quarantine off in a space by themselves because whatever, they live with 6 other people, they share a bed with 2 other people. Just that's the way it is in New York
Wow.
and in these communities.
So, I read that one of the ER doctors at your hospital, Lorna Breen, who treated coronavirus patients, committed suicide.
Yes,
Did you know Dr. Breen?
I did.
And how did that affect you, and how did it affect the other nurses at the hospital?
Um, I think we're all still being impacted. It didn't seem real when it happened, and I think her family has taken quite a bit of time to tell her story. You've seen the New York Times articles about her story. Um, but what she described in those few days that she was back after recovering from the virus herself, and I say recovered like this because I don't really believe that she ever truly recovered. Um, a little bit of a side note, we're finding out that this disease has so many neuropsychiatric effects.
Oh,
Really? I didn't know
Yeah,
that.
sure, sure.
I think the one that has been put out there a lot is stroke, which is true, but that's just one small subset of the neuropsychiatric complications that can happen. And I think that this virus, on top of course, the other real issues of, total loss of control and seeing all of this death in the ER and all of that, I think that the virus also impacted her in a way that made her not able to handle from a psychological standpoint,
How were you able
which
to
is
handle it?
frightening.
Yeah.
Um, I don't know that we're really handling it. I guess we're just getting lucky by surviving each day. I think, my daughters help a lot because their innocence is really healing in some ways. I was petrified when this whole thing started. My younger daughter was 4 or 5 months old, and I'm inundated in this virus. I have two parents in their 70s, 40 minutes away. I'm breastfeeding, so how do you socially distance from that? And really know what to do. So I tried to figure out the best protocol I could in terms of coming home, washing the clothes and burning water and showering, whatever. And I think, you're forced at the end of the day with a 5-month old and a 4-year old to draw pictures on the ground, and in some ways that really helps to at the very least distract you from everything else going on.
Lizzie?
No, so I'm just looking at some of the questions that are coming in on our website. And so we have a question from Mike Winter, and he's asking, from your point of view, are people who had COVID, are they getting reinfected, really getting it twice? What is the story with that?
For the most part, we have not been seeing people get reinfected. That being said, I think it's too early to tell whether people are going to get
Because
reinfected
sometimes the
or
antibodies take a little while to develop, or to take, or they may give you 6 months of protection, and then
exactly. So the timing of how long antibodies will last is a question mark. The other problem is, with the whole reason the whole question from China didn't work is that it was a different strain of this virus. And so viruses are smart. They mutate, and just because you're exposed to one brand of this virus doesn't mean you can't get impacted potentially in a worse way from another. So the security that we unfortunately all banked on from having gotten it one time doesn't necessarily hold in terms of
And I
helping
think
you to
that,
feel safe.
and I think that's a key point that you just made about how viruses take on different forms. They, form different strains. And I try to explain that every year to people who talk about the flu and the flu shot, and why this flu shot may not work this year. And I'm just like, well, because the strain is different. Like, viruses mutate. And I don't think that there's a real understanding of that, with the general public. But also, I want you just like to speak about the idea that it's okay to get it if you don't die. Like you hear a lot of people talking about, okay, well, yeah, I got the COVID, but it's just like the flu. I'm not dying, so it's not a big deal. When we don't really know the long-term effects, right?
Right. One very scary thing is that we don't know the long-term effects, and the other thing we don't know is, how do you know if you're going to get this super mild version or not? We used to think that we know, like, if you have certain comorbidities, if you're older, whatever, this puts you at higher risk. But those those stereotypes or cliches don't always hold true. In the peak, we had two 28-year-olds in the ICU who had nothing else besides having a little extra weight on them, no other diseases or comorbidities. So you just really don't know. It has so much to do with things we cannot see, in terms of what you're going to get. And so it's really problematic to send that message, which I think was very prevalent in terms of, like, most people will just have a mild cold and they'll be fine. We really don't know.
Jam.
I'll hit you with my question after one of our other listeners asked, can you speak to the different tests and the effectiveness of those tests? A reporter said there were 4 tests he knew. I'm not sure. A reporter said they were, I guess, took one test that showed that they came back negative, but they knew they were positive. Can you speak to your preference, I guess, or what you know about the tests?
That's from Karen Andrews.
Yeah. Our tests have gotten a little better in terms of what they are and how fast they come back. Now in our hospital, can probably get a test result back in about a day, which is a
Mm.
big change from before, where we had to wait a couple of days. In the beginning, we were doing swabs through the mouth into the throat and also through the nose, and now the one through the nose is the only one that we use. The accuracy is still only about 70%. And I don't know if any of you have had the test. You really need to go up in there for it to be an accurate sample, and it's highly uncomfortable. Um, and so the person doing the test and the tolerability of the test matters in terms of the accuracy as well, to make sure you're getting a good sample. So at best, we think that the accuracy is about 70 to 80%. We saw many cases where the test result was negative, and we just presumed, for safety purposes and for public health purposes, you have it. I don't care what this test says. You need to protect yourself, your family.
Right.
You had
Right.
another question, Jim?
Yeah, I had a question, and this was partially addressed earlier, but I wanted to just walk through it a bit. We talked about stress for you personally, but I was also thinking about that, like, how do you handle stress? We talked about that with the kids and you a bit, but feel free to expound. But also, as you guys plan for phase 2, how much is that going into the conversation as for the group that you work with? Like, where does that fall? Has that become more important because of your experiences? Um, Things like that.
Oh, definitely. I I really see myself as responsible for these 18 other individuals who I train every year, and so both in this peak as well as in the next one, we were highly aware of the psychological impact of seeing so much death in a day. One of my first year residents this year had like 3 people die in an 8-hour period, and I just had to tell him to like go home and be with other people and not be in this environment. So one of the first things we did is limit their time that they have in the hospital. So my job, I'm there 5 days a week all year round. And usually the residents are there for 2 to 4 weeks at a time, but we told all of the other residents that they cannot be there for more than 1 week at a time physically, both for exposure purposes as well as for like mental health. And we also have these what we call biopsychosocial rounds every Friday, that where we come together as a group now to really talk about the traumas that we have seen and experienced. And I think that will continue as well. We're a pretty tight knit group, and so I think that one of the nicest things about being in a hospital, if you have to be in a hospital, is that it's a team environment, and we really are a family, and we do look out for one another pretty well.
All right. Z?
I was just
To
looking
kind
at one of the. Oh, I'm sorry,
Z.
Lizzie. It sounds the
Sorry,
same. Go
sorry
Z.
about that. Z, yeah.
okay. To just kind of go back to the actual test, is there any limitation to how often you should be getting this test before it maybe does other damage? You know, like it seems like a pretty, like you said, a pretty rough test to take already. Has there been any danger of, how to sound not stupid, but injuring things while you're actually piercing membranes, piercing a brain? I don't know.
Yeah. I suppose there is a theoretical risk of trauma, but I haven't heard of anyone experiencing lasting trauma. In the tests that I have gotten, it hurt for like a few hours, but no permanent damage done. And I haven't heard of any cases where repeated tests and or a single test have caused lasting trauma.
So I know that we're aware that it's hit the Black community, the Hispanic community, and people of color pretty hard. Can you tell us what you've seen as far as that?
I mean, that is the reality, and that is potentially like the saddest thing of all, in terms of how this is going to manifest in the future. I mean, of course, we know that these communities are so vulnerable in every context of our daily lives because of the way we treat them as a society. But the virus just made that all the more clear in terms of where do people of color in New York City live? What are their housing situations like? What are their resources? Where do they go to get care? And how is their aftercare, discharge follow up, and access to medical providers after the fact? And we know for years, not just with this virus, that people of color in neighborhoods of, the Bronx, Upper Manhattan, are going to die more so than other people in different communities who are white, have higher socioeconomic status, which we know are also intertwined because of racism. And that's a harder battle to fight, in my opinion, than the virus itself.
Mm.
All right.
The virus will eventually go away. It'll take a while, another year or two, but this is a problem that is going to, I think it's a much bigger problem that's going to take years and years. And with the death of George Floyd, and we've been thinking about it a lot in terms of as a department and trying to address institutional racism within our hospital and trying to do very concrete things to help change little things that happen every day. So, for example, some of the projects that we have been working on is changing the paperwork that our patients who are undocumented and or uninsured get in terms of where they can get care. We are trying to address our institution's report of different lab results. Right now, believe it or not, we get lab results, and this isn't true for just our hospital, this is across the nation, where there's a result for people who are African American, whatever that means, whether they self-identify or someone else assumed they are or whatever, and those who are non-African American. And so we are trying to get all that type of race-related data out because it's, in my opinion, crap to begin with. And that's just one or two examples of the things that we're trying to do now.
We have a couple of minutes. Jan, you have a question? Go ahead.
Yeah, real quick to hop onto that. Have you guys had any experience with the new recording guidelines that were required by the White House and the administration? Have you had any direct experience with that and those changes?
We have not as of yet. No.
Cool. Just curious.
Last question, Lizzie.
I was just going to go to, again, one of our viewers. He's asking, as a physician, how do you suggest dealing with family members that say, we are a family, so we don't have to follow the same guidelines while being in this pandemic. We don't have to wear masks. We don't have to socially distance.
And that's from Rupka.
Well, I think the problematic part of that is that, it's a false sense of security that you're going to be safe with the ones you love or that you're used to and live with, because you don't imagine that those people can ever harm you or hurt you in any way. And no one may do it intentionally. And the problem that is that, even us who are studying as scientists or as medical professionals or whatever, we know almost nothing about this disease. So collectively, we have to stay on the side of caution. We have to protect each other. I have not hugged my parents since before this whole pandemic started because I know I'm exposed, even though I've never gotten the virus, because I don't want to risk it.
How often are
What
you
happens
tested?
if you're sharing? Yeah.
Sorry.
How often are you tested?
It varies. They only started testing asymptomatic healthcare professionals at my hospital very, very late in the game, like end of April or May, after our peak had already happened. So I've only been tested twice without symptoms since this whole pandemic started. But I've been lucky enough to never have had symptoms.
All right, Z, I'll give you the final question. Go ahead.
Well, no, just to kind of touch back on, socially distancing within families, does that extend to like nuclear families, families who are actually living together? Because as you said, living in the Bronx, a lot of us don't have the space to socially
Yeah.
distance. So what's the point of being uncomfortable with a mask on and not hugging when you're already in close quarters? Is there really anything more that you can do, I guess, in that case?
I think that it's very heartbreaking for the people who don't have the space to socially distance. But the best that we can do is try to limit our close quarters with one another. If one person's in the house, the other person stay in the back of the house. If you're going to be within 6 feet of each other, wear the mask. At least if you're more than that distance apart from each other, then you can take breathers, take your sips of water, eat your food, then put your mask up, clean all of your surfaces. Your call if you want to wear gloves or not when you're around other people, but we do know that the virus lives on different types of surfaces, some longer than others. For example, that's where that 3-day rule came from with Amazon packages for 72 hours because of how it lasts on cardboard surfaces.
All right. Well, Dr. Ekanatom, I truly want to thank you for joining us. This has been so insightful. I know a lot of the people online I know there's still some questions online, so we apologize if we didn't get to all your questions. I still have some more questions, so maybe at some point, if you don't mind, we may bring you back if that's okay and ask some more questions. But thank you so much for joining us.
Thank you
Thank
for
you so
having
much.
me.
All right.
Thank you.
Thanks
Appreciate it.
again. All right.
Bye-bye.
Have a good one.